Welcome back to Pete's Crit. We're here discussing NAVA with Dr. Guillaume Emeriaud. Please correct my pronunciation of your name and let the listeners know where you work, and then we'll get started with update on the case.
Yes, so that's Guillaume Emeriaud. That was perfect. And I'm working at Sainte Justine Hospital, University of Montreal.
Oh, wonderful. Thank you. So jumping back into our NAVA discussion, we gave you a 4-month-old X28-week infant with respiratory failure secondary to RSV bronchiolitis. We're initiating non-invasive mechanical ventilation via NAVA. How do you choose the initial settings for this patient? We've got the esophageal probe. We're connecting it to the servo-U. What settings are you starting with?
So as I mentioned in the previous part, you have not a lot of things to set, but the PEEP, the NAVA level, and the FiO2, and also the backup ventilation and the alarms. And so for the PEEP, to be honest, probably this patient is already on a PEEP of 8 or 7 or 10 sometimes. Usually when we start NAVA, either we keep the same PEEP or we decrease it slightly because we add an inspiratory support. Usually we'll start with a PEEP of 7. And then comes the question for the NAVA level. For the setting of NAVA level, in fact, in non-invasive ventilation, you won't make a lot of mistakes if you just pick a number anywhere between 0.5 and 1. To be honest, I would say maybe let's start with 0.7 or 0.8. The point is that this patient probably has a high diaphragmatic electrical activity, and that's what you will check when you make the decision. You try to understand where the patient is and where you want to go. The point is that the patient probably, let's say, has 40 microvolt of diaphragmatic electrical activity, which is high. It's higher than usual. Usually it's below 20. And so you have 40. So you can calculate, in fact, the level of pressure that you want to deliver to the patient based on this number. But the problem is that you don't want the patient stay at the 40. The goal is that you want, in the end, it will decrease maybe to 30 or 20. So instead of considering 40, let's consider 20 because that's the goal. If the goal is 20 and you have set the NAVA level to 0.8, then this means that the patient will receive 0.8 multiplied by 20, which is 16, which seems quite high, 16 centimeters of water in addition to the PEEP. But we will limit that with the maximal pressure alarm. But as I mentioned, it's usually we set the alarm at 25, which will limit the delivered pressure at 20. And so the patient will receive, in fact, a synchronized NAV on 20 above 7 for a while. And when the ventilatory drive will decrease, then the pressure will automatically decrease. If the patient stays above 20 but is comfortable, then you will decrease the NAVA level progressively, and this will decrease the pressure that the patient is receiving. And of course, you have to remember to set backup ventilation because if the patient pulls the catheter, for example, then of course you won't have the EDI signal, and then you want the conventional triggers to be active.
Seeing if a patient is appropriately supported on non-invasive ventilation is core to what we do in the pediatric ICU. And one of my typical strategies here would be to make the adjustment. Not uncommon, these kids get really agitated with changes in their mechanical ventilation or non-invasive ventilation. But what I'd like to see over those next couple of hours is a decrease in the FiO2 requirement, decrease in the heart rate, decrease in the respiratory rate. When you have NAVA, how much do you use the physiologic and clinical variables? How much do you use what you're seeing on the EDA-DI? How do you put those together to determine if a patient's adequately supported?
Yes, in fact, in the same way, it's just an additional information that you have. So seeing the decrease in EDI would be important. I think if the patient is very high, this is a sign that the patient is improving, but that don't prevent you to look at the patient. And we have sometimes patients, especially with neuromuscular disease, that keep having a very high level of pressure, but they are comfortable. So then that's fine. You don't have to increase the support just because the EDI is high if the patient is correct. So it's very important to keep an eye on the patient. It's probably the basics for the PQ, but any people in the PICU, but this stay the same in NAVA. So looking at the effort of the patient, at the respiratory rate, heart rate, and the comfort, it's very important. Also, an important point is that it's connected to an interface. And so there are always a lot of leaks around the interface. routinely use total face mask in those infants, and that makes a difference in our experience. But of course, there is some variability across different units. But this provides the pressure more rapidly to the patient and more efficiently, especially as compared to cannulas or something. So if you think in terms of efficiency of the NIV, the mask is probably more efficient, but it's also leaky. So you have to look at the pressure that the patient actually receives. Because, when I calculate the NAVA level, I mentioned what should be expected. Like probably you should expect that the patient will receive 20 on 7. But in fact, that's frequently not the case. And because of the leaks, the patient will be on 18 or 16. And if the patient is okay, that's fine. But pay attention to that because it also reflects the leaks, the magnitude of the leaks. And if the patient is responding well, that's okay. If the patient is still struggling, but you only obtain 10, for example, above 7 of pressure support, it's no use to increase the NAVA level. You just fix the leak. If the patient does not receive the pressure that the ventilator is trying to give. So looking at the pressure that are delivered that is also important.
Oh, absolutely. Sounds like such a precise measure of what the patient needs. And then if you lose it all with tiny nasal prongs or something, then I could see that being ineffective.
So say you're delivering the pressure that's intended, but your patient over the next couple hours after you've started NAVA is still having worker breathing that's maybe moderate to even severe. Your electrical activity diaphragm is still high. How would you titrate that therapy? How much would you typically increase the NAVA level? At what time interval would you do that?
Yeah. So you're at the frontier of intubation, quite in this patient who is quite sick. You have started first-tier therapy with, I can't remember if it's CPAP or high flow or both, and then you escalate to NAVA. And so just keep in mind that you always should wonder if you are not at the step of intubation, especially if the patient requires oxygen, which is unusual in this situation. So maybe above 40 or 50% is unexpected if the patient is not improving, etc. If you think the patient is correct, you still have some time, then there are a few things that you can do. But if the pressure maximized, increasing the NAVA level would not make a big difference. So you have the choice. Do you want to allow a slightly higher maximal pressure? And then that means that you will allow the pressure maybe reach 22 instead of 20 on an NIV. And to be honest, we do that sometime. But then when I do that, I'm always a bit worried that we have more risk to be in the situation. The patient wants more, still fighting. And so that's an uncomfortable situation. I would continue. I would increase to 22 for a few hours, but as soon as possible, I would decrease to 20. But I would understand completely that another people could say, okay, let's intubate this patient.
Oh, nice. In that scenario, do you think the primary dependent variable you're using is really what's your pressure alarm or 5 below your pressure alarm and how often your patient's hitting it, and EDI is 20 and the EDI is 40?
The level of pressure, in fact, this is what you set almost. And so you have to accept that at the beginning. So what would alarm me more is how the patient is responding to that. And so if the patient is not improving, if the the respiratory rate has not decreased, the EDI has not decreased, the respiratory effort has not decreased, this would be what makes me worried. In fact, the oxygen is very important, but more probably for other reasons for NIV. In bronchiolitis, it's quite rare, but in pneumonia, an oxygenation of above 50, 60% also would be an alarm for us that it's failing.
One thing that I wanted to emphasize in NAVA, it's not that you achieve a certain NAVA level and that's how you define failure. It's you're adjusting NAVA, you're looking at what pressures the child is receiving, and we still use the same technique that we appraise our kids at the bedside. We're providing high levels of non-invasive ventilatory support. This child is still working to breathe. This child still has respiratory failure. We're not going to base our decision to intubate them based on what the NAVA level is. It's how are they responding to the therapy we've provided them thus far, and where are we at in their trajectory of illness?
Wait, but would the EDI push you to intubate, though? If I gave you a patient who was hitting your max of 20 and the EDI is like 20 versus 40 or
I think that would be reassuring for me. Okay. I would put that in the context. It's one variable among others.
Okay.
You cannot base only on one variable. Something that came to my mind is We started with 0.7 or 0.8. I think in this patient, we would probably increase to 1. We just want to be sure that the patient received the maximum, but it doesn't really make such a difference, as you said. I think the one step that we would probably consider, but probably it's already begun before, it's the sedation, of course. Also, at least to make him comfortable. You have to be prudent with that. You also want the patient to stay awake and ventilate, but you want him to not fight against the ventilator. And so.
Yes, wonderful. Sometimes I reflect, with the 10 things that are a bit more experienced than I, how in the world could you deliver care in the PICU without dexmedetomidine and IV and high flow nasal cannula? But that dominates much of the conversation on rounds these days.
It sure does. So we're working with this 4-month-old X28 weeker with RSV. Say you've done your non-invasive trial and they fail, they develop refractory hypoxemia and workup breathing on their non-invasive NAVA and require intubation. Once the paralytic has worn off, is there a role for NAVA in invasive mechanical ventilation? Would you support continuing to use?
I would say that probably we are entering an area where the benefits are possible, but they are less clear, and I think it's more a controversy. But yes, in fact, there could be a place. Of course, initially, when we intubate a patient like that, we would start with a conventional invasive ventilation, especially that the patient is usually deeply sedated and paralyzed at the beginning. But then will come the possibility to maintain the patient participation in his ventilation. Pressure support ventilation is doing that, but it's difficult to achieve in small kids to maintain the correct inspiratory time at a very high respiratory rate, etc. But NAVA usually can do that. So that would be a situation where this could be interesting to maintain the activity. Why? To improve the recruitment of the patient, the lung recruitment, in fact. Maintaining an activity has an impact on the dispersion of the pressure and different aspects of the lungs. In fact, the dorsal region of the lungs would benefit from an active inspiration. And this is something that comes when you look at impedance tomography, for example. There are increasingly amount of data that shows that, in fact, maintaining the spontaneous ventilation could allow more recruitment of the dorsal area, for example. Maintaining the diaphragm activity is also important for the weaning period. In fact, this will probably accelerate the weaning because the patient will be awake sooner and more rapidly efficient at ventilating. And also, one of the advantages when you use NAVA in this type of patient is that you will see that the nurses are more prone to sedate them rapidly and paralyze them rapidly, etc. Usually, we maintain a level of participation that it's probably higher than in conventional ventilation. In this type of patients, to be honest, it's not easy. Sometimes they have crises and they block themselves, thoracic blockade, and they just crash, And so if you are on NAVA, you have to be very reactive and sedate them, paralyze them, switch to conventional ventilation. And so usually for a few days, it's not that easy. So I would say that it's a difficult situation. But it may be helpful for the participation of the diaphragm, maintaining that. And for the oxygenation at lower level of pressure, usually you may see a benefit. But as I mentioned, this is an area where the differences between the modes should be explored, I think. It's more habits of the unit, Also, it can facilitate the transition to the extubation because then you just pull the tube and you go back to NAVA and continue like that. But so for the weaning phase, it may be helpful too.
I will say, just in our local practice, we use NAVA infrequently. And the patients that we would generally never use NAVA are the ones with multi-organ dysfunction or rapidly worsening respiratory failure. And whether it's correct or not, I feel more inclined to be able to control things more when kids are getting sicker and their trajectory illness is worsening quickly. Would you say it's a general theme for you as well?
No. I think that's the safe way to go. We do the same, and the same for cardiac patients. I mentioned, the two different strategies that we have in cardiac for the decreasing the pressure for the right side and weaning phase for the left side. But if the patient needs pressure, like patient with, as you mentioned, with multi-organ failure or a myocarditis with a low ejection fraction and in shock, of course you want the pressure that will help the patient, and switching them to NAVA will probably worsen them. So there are points where you want the patient contribute to the ventilation, and there are situations where you want to take control. And that's important, and that's the safe way. One thing that we are trying to maybe alert people is that we frequently feel that it's better to control everything when the patient is ready to take the lead, in fact. And that's where, in fact, using EDI monitoring, maybe even if you don't use NAVA at the beginning, will inform you that, okay, we are probably over-sedating, over-ventilating the patients. Maybe it's time to let the patient breathe. But this is also the role of protocolized weaning or protocolized detection of patient extubation readiness, and that should compensate for that. But usually we over-ventilate our patient, and usually we over-sedate our patients. But there are situations clearly where you have to be proactive and take the control.
Oh, absolutely. The recognition of patient improvement and doing less.
And if I may, also, for example, for patients with brain injury or patient with pulmonary hypertension, if you want to set pH value, that's impossible. In NAVA, the patient will set the pH value, and he will be remarkably stable with this pH value. We have looked at that, and in fact, it's less variable, which is probably great, but it's usually lower than the pH value that you would want if you control the ventilation. So if this is an objective, then probably you need to take the control.
Oh, nice. Now, when we are using NAVA in mechanical ventilation, maybe at sign out, you're telling me about the PEEP, the NAVA level, what the EDIs have been. Do you also pass on what the pressures have been, whether they're hitting the max pressure? Are you talking about the tidal volumes the patient's pulling? What ventilator variables are you trending and looking at?
Yes, that's a great question, because in invasive ventilation, then it becomes even more important to pay attention to these variables. And especially for the tidal volume, for example, because then you don't want the patient to be ventilated always at 12 ml per kilo. One of the difficulties is that it's highly variable. It varies one breath at a time. So every breath, the numbers are changing on ventilator. And so that's a key point for all the cases in NAVA that we should emphasize, is that you have to look at the trends, not only at the screens, but go back to the trends over the last hour to 6 hours, etc., to see what the patient is doing, because it's variable. So it's very important. And so you see also the improvement or deterioration of the patient, but also what is the current ventilation. Paying attention to the tidal volume is important because it's not set. So it's very essential to make sure it's in the window that you consider safe. Interestingly, when you look at that, most of the patients adopt a relatively protective ventilation with a small tidal volume, but a few patients take 10 ml per kilos. And then you have the question, is it good or bad? And so you have to make your decision. And as I mentioned before, probably the patient will take that even if you switch them on pressure or even on volume control. But this is an important situation. Usually the patients that do that are patients with normal lungs, and the transpulmonary pressure is not that high, but you have to measure it. And it's not that easy in NAVA. In fact, even the driving pressure is something that's maybe a bit tricky because you underestimate the driving pressure. You see the pressure that is delivered by the ventilator, but you don't see what the patient is doing. So you can measure the occlusion pressure. I would refer to the work by the team of Robin Derkemani, and there are published several papers on that. Either you do a manual occlusion at the end of inspiration and you see the plateau pressure that will increase, and so you can estimate the driving pressure, or you do an occlusion maneuver at the expiration and you see the occlusion pressure, what the patient is doing when he's breathing. And so you can have an idea of what actively delivered to the patient. So it's very important, especially if the patient takes deep breaths, in fact, just to make sure we are in a safe window. But then it's also the same as in any ventilated patients. Here they're comfortable, the respiratory rate is okay. Usually they have a relatively high respiratory rate, so we increase the alarms, and it's important not to be afraid of that because it also counts, even the small breaths are counted in the sum, so it's not unusual, but if the patient looks okay, we tolerate that.
Oh, nice. Yes, a little freaky to have your patient taking like 3 ml per kilo breaths at 70 breaths per minute, but I guess if they like it, you know?
We've already mentioned earlier in this discussion is that NAVA can be an effective way to help us wean mechanical ventilation, whether it's invasive or non-invasive. I'd like you to explore some of those principles with us, how you would get this done. And if it would be helpful, we can talk about this in the context of non-invasive or invasive. We can even use our case, our X28-week premature baby who's now here with bronchiolitis.
Yes, so it's a difficult question, in fact, very large and depend a lot on the patients. In fact, we have simple to win patients should be win quickly. In fact, that may be a danger of NAVA, because if you want to win them point one by point one, it could take years or days.
Yeah.
But in some very sick patients where you want to be prudent, sometimes you will go point one by point one until point three, before extubating them. Sometimes we do that with chronic patients with severe BPD or that have been very difficult ventilated for weeks or months. Then we may slow maybe every week or twice a week, we decrease by 0.1 and just see if the patient tolerates. So it could be very slow sometimes, but the patients more that depicted in the clinical vignette should be win relatively fast. So if he's on NAVA, let's say at 1, then the transition would be to go to 0.5, and if he's tolerated, then you have a difficult position, because should we do a spontaneous breathing trial or not, or is it already a spontaneous breathing trial? In fact, it's like a spontaneous breathing trial, but you have to pay attention to the pressure that is delivered, because if the patient receives 25 above PEEP or 20 above the PEEP, this means even at low level, because the patient has a high drive, this is not a spontaneous breathing trial. This is a support. And so that means that the patient is still sick, etc. So this is not the NAVA level. This is the pressure that the patient is receiving. Tell you where you are. So we decrease the NAVA level and you look at the pressure. If you have a low level of pressure, like whatever, the patient is on 12 above 7 or 12 above 5, whatever the NAVA level is, then you know that the patient is not receiving a low level of support and you can extubate. Some of my colleagues will prefer to do an actual spontaneous breathing trial just to make sure we use the same numbers as other patients, but that would be the way. In non-invasive condition, I would also support to go, especially in acute patients, relatively fast. You are at 0.8, you go to 0.5. If it's okay, you go to 0. And if it's okay, you remove the CPAP. In fact, interestingly, a NAVA level of 0 is sometimes used. It's not exactly a CPAP, because you see the little blip, and probably this is the pressure compensation by the ventilator. So, in fact, the patient receives a bit more support than completely 0, but usually that's an equivalent to CPAP. Yeah. One anecdote maybe, but if you look at the work by Merja that I mentioned did the first PQ RCT, she also has done a NICU RCT in intubated preterm babies. And one of the problems in this study is that as soon as she intubated the patient and switched on NAVA, in fact, they reach the extubation readiness criteria. And that's just to illustrate that, you just intubate the patient and they are comfortable, they need low level of support, but you just intubate them. They're still sick. So you have to relearn how to extubate these patients, in fact. So it's a bit tricky sometimes.
Oh, that's fun. It's like I can hear you roasting us at sign out of take it out, weed the NAVA.
Yeah, that's one of the strategies. Always try to move on.
I think one pitfall to acknowledge here is that when we incorporate modes of ventilation that not everyone is comfortable with, there is the potential to slow things down for these patients. And it seems like locally, you likely have lots of institutional knowledge and familiarity with NAVA. And I would imagine that really helps implement this mode of ventilation, progress kids along. And for listeners who are thinking about incorporating more of this in their practice, considerable amount of education that it would take to be able to support these patients the best possible.
Yeah, you're totally right. And that's why, in fact, I think NAVA is not everywhere. I think it's when you use it, you see improvement sometimes, especially in some certain conditions. But doing the first steps is not so easy. When nobody in the team has seen NAVA, of course, it may be a great challenge. And so that's why I think it's important to start with easy patients and probably NIV patients, and then the ones where you want to make a difference, but not the more complex ones. It takes time to build the experience for those patients.
What do you see as next for NAVA in pediatric critical care? This could be regards to, do you see it becoming more popular or less popular? What do you foresee as next scholarship that's needed here?
I would be sad if it's not increasingly used. I think it's a waste of chance for our kids, especially for NIV NAVA. I think it's such an improvement when you see it that We clearly avoided intubation in some kids every winter. But we understand completely why it's not so easy to disseminate. I think the next big part for NAVA is to construct a stronger evidence. So we are working on comparative study and, if possible, to develop a randomized controlled trial to show a benefit and to demonstrate that it really helps. And that will make it easier to disseminate the technology. For the invasive ventilation, I think we are still at the phase where it's exploratory. I think we have to do more research on that and to see the behavior of the patient. But of course, this will be even more important in this situation to do more controlled study and to see a benefit. It's not easy to show a benefit in mechanically ventilated children because, in fact, they do well usually, but we have to find more reason to use it. But let's start with an IV, I think.
Well, wonderful. Are there any key points or references that you like to highlight for the readers as we wrap up?
Well, I think probably I mentioned that several times, but yes, it's an amazing tool. It's very informative. When you start using it, you understand a few things that you did not realize when you're not looking so deeply in your patient, in fact, during mechanical ventilation. So it's very informative, but it's a tool. It's not a treatment itself. It's a treatment, but if the patient is very sick, he will scan. Sometimes I hear, NAVA has failed, but it's not NAVA that failed. So that it's the patient is sick. NAVA was not the right tool at this moment. And so it's important to just also let the time for the patient to recover and improve. But it may help in certain situations. But you have to be prudent and to get the same behavior that you have with any kids in mechanical ventilation. Understand what's happening, how the ventilator is working, and look at the patient and is the patient improving or not? Is it more time for letting the patient do by himself, or is it the time to take control, as we mentioned? I think it's very important to keep that in mind all the time.
Well, this has been incredible. I'd like to thank you for your time and expertise. I know I've learned so much, and I'm very excited to share this with our listeners.
Thank you so much for the invitation. It was a pleasure for me, and I'm sorry if I'm too wordy. I love that subject, so sometimes